Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Rouleau University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we are coming back after all of our guests had stopped by our show to round out our discussion on colorectal cancer, this time focusing on rectal cancer. Another super high-yield episode. This is going to fit in so nicely with the prior discussions we had with Dr. Sanford and Dr. Bailey. I'm just excited to get into some of the medical oncology perspective today.
Yeah, and as part of this, even though we're medical oncologists, we really need to understand short course and long course radiation, advancements in surgical techniques. So we're going to go through all the data. It'll be in our show notes. This really helped me understand long course and short course radiation a lot better, and I hope it does the same for you guys.
Yeah, whenever we're taking care of a type of cancer that has a lot of different specialties involved, our role becomes analogous to that of the PCP. We have to be the one who's quarterbacking all of these different subspecialty, subspecialty involvements. So very important to know this.
All right, guys. Well, then without further ado, let's roll that show. Guys, this is our first episode after our recent vacations. Vivek, how was Portugal?
Oh, it was great. Portugal was absolutely fantastic. Highly recommend. Porto is one of the greatest cities on earth. I mean, it's basically like being in Harry Potter. I think a lot of people from Porto probably get a little bit annoyed that we always talk about its similarities to Harry Potter, but really just a very, very cool city. Love Portugal. Portuguese people are so nice. Food is incredible. Highly recommend to anybody. But Ronak, you went to Japan, which, has been a dream of mine. So how was that?
Japan was also phenomenal. Equally a beautiful country. There's never not something to do. Like there's just things everywhere. The food is fantastic. The people were wonderful. Public transportation is so clutch. And the fact that even little things like being able to use the same card to get on buses and trains, no matter where you are in the country, was so clutch. It was just awesome. We spent a whole 2 weeks there, and it was nice to be able to explore a country that seems to have figured out a ways to do a lot of things really, really well. But, after coming back from Japan, I almost immediately then had to go up to Philadelphia because my brother graduated with his MBA this past weekend. And we also, as part of that, had to move some things out of a family member's apartment. And let's just say I have a fun story about this because I had to rent a moving truck that I drove. And everything went fine. We got the moving truck back to the place that we picked it up. And just as we were closing the doors, we realized that I left the keys in the ignition. And so,
big mistake.
I know. Mistake. Well, I wasn't thinking. I quite frankly have never driven a car that has manual windows or locks. And so like the thought of a car locking with the keys inside is alien to me. So the keys are inside. We go to the desk. We're like, hey, do you guys have an extra key? And they're like, no, we don't keep that. And they said, you have to talk to the roadside assistance people who were wanting to charge $210. So as a broke fellow, what I did was I turned to everybody's favorite resource, TikTok. And I found a TikTok video where they use packaging tape to pull open windows if they have the crank. And that is exactly what I did. So I went inside, bought $10 worth of packaging tape. I can now tell people that I've broken into a vehicle. We pulled that window down, and then I lifted my wife up as the window opened up and she was able to slip her hand in and get that lock open. So I must say I'm feeling pretty proud of myself for doing something a little bit uncharacteristic for what I'm normally used to.
Look at you moving to Philadelphia and already you're just breaking into cars. That's fantastic.
I'm fitting right into the culture.
You're embracing your Philly. You're embracing it.
That's right. That's right. Our listeners don't know Chris Can just yet. There'll be an episode with Chris Can. I'm going to have to text him and let him know I'm really getting into the Philly lifestyle like he has. So more to come, I'm sure. I'll have more stories like this in a few months to share with you guys. It's just the beginning.
Yeah. When Ronak moves there, I mean, he'll be true Philly. He's been suppressing it, but I'm glad to have him finally bring that back out. But let's move on. Let's get started with the episode today. So, in usual fashion, I'm just going to kick us off with a case, and then let's talk about some concepts in rectal cancer. So we have a 56-year-old male with type 2 diabetes and hypertension who developed watery diarrhea that was attributed to metformin. This was stopped by his primary care provider without improvement, and he subsequently developed weight loss and rectal pain. He underwent a colonoscopy that showed a partially obstructing tumor in the rectum with biopsy consistent with a moderately differentiated adenocarcinoma. The tumor was found to be MMR proficient and microsatellite stable. Baseline CEA was elevated slightly at 35. Staging CT chest, abdomen, pelvis showed the rectal tumor with a few prominent lymph nodes and was otherwise unremarkable. He then underwent MRI of his pelvis, which demonstrated a T4A tumor, positive mesorectal lymph nodes, and positive extramural venous invasion. There was noted threatened circumferential margin as the tumor was within 1 millimeter of the mesorectal fascia. Lastly, the tumor was 11 centimeters from the anal verge. He now presents to medical oncology clinic to establish care. So in our previous radiation oncology and surgical episodes, we talked about the management of these patients, but I just listed a whole bunch of terms there about the MRI. So can one of you just go through how we approach a new patient that's diagnosed with rectal cancer?
To start, remember that rectal cancer is, in fact, a different type of disease entity than colon cancer. We tend to lump them together, but when we're talking about rectal cancer, we're talking about tumors that are up to 15 centimeters away from the anal verge. From there, we divide the rectum into thirds, talking about low, mid, and upper rectal tumors. So, by 5 centimeter chunks, essentially. 1 through 5 centimeters from the anal verge is considered a low-lying tumor. 6 to 10 is a mid-rectal tumor, and 11 to 15 centimeters is an upper rectal tumor. And rectal cancer is really all about preoperative therapy with either chemoradiation, chemotherapy, some combination of these interventions. And as a medical oncologist, you'll need to know a few things to make sure you have your patient on the right track. First up, we need to know the microsatellite stability and or mismatch repair status. This can really impact management and could spare patients both concurrent chemoradiation or even surgery. In addition to CT imaging, it's also essential to get a pelvic MRI for staging. This is how we assess response after neoadjuvant therapy as well, so it's super important to have that baseline up front. But the MRI report will actually give us a lot of features to help us risk stratify patients and figure out who's going to end up needing total neoadjuvant chemotherapy and chemoradiation. The first thing to pay attention to is the T stage of the tumor. If the MRI report is saying this is a T4 tumor, that's a tumor that needs neoadjuvant chemoradiation chemotherapy. Additionally, we'll get some indication as to how much sphincter involvement there is. So if the tumor is within 5 millimeters of the anal verge, it's a very low-lying tumor, and they'll often have some sphincter involvement. Remember, if sphincter is involved, that may require an APR, which leads to sort of permanent ostomy. And so for these low-lying tumors, we'll often do neoadjuvant chemoradiation and chemotherapy to see if we can allow for a sphincter-preserving surgeries or an organ preservation type of procedure. The next thing to look for is involvement of the mesorectal fascia. Sometimes this is referred to as a threatened circumferential resection margin. So if the tumor is within 1 millimeter of the mesorectal fascia, we know that that's a prognostic factor for local regional recurrence. So that's another indication for total upfront therapy. You can also get some indication of whether or not there's extramural venous invasion. This is another high-risk feature for distal recurrence. And finally, lateral pelvic lymph node involvement, another feature that is a good indication for doing neoadjuvant chemoradiation chemotherapy. So a lot of stuff on that MRI report that can help you figure out, again, which path your patient needs to be on.
So what I'm taking away from this is that we need to know a few things. Number one, we want to know the MSI status. We want to get a CT and a pelvic MRI. And you can see how important it is to get the pelvic MRI from what Dan just discussed and from our prior discussions. And what this highlights is that accurate preoperative staging with an MRI is essential to guide treatment decisions in the modern era. And this was lacking in many of the historical studies that led to high rates of local regional recurrence. And honestly, that makes it kind of difficult to interpret these studies in the modern era. So I think that we need to take some time to go through the historical context and historical basis for neoadjuvant radiation therapy and surgery with total mesorectal excision. And this understanding is so important to help us understand why it is difficult to interpret the role of adjuvant chemotherapy in these older trials. So Vivek, as our resident historian, can you walk us through some of this information?
So we have to go back to the 90s. This is a good time in life. I mean, let's be real, right? As millennials, we love the 90s. So back in the 90s, remember that we talked about in our previous episodes, this is when we were using 5-FU-based therapies as adjuvant chemotherapy. The interesting thing is, though, and we knew this, and investigators knew this at the time, that for rectal cancer, one of the biggest problems was local regional recurrence and quality of life after surgery, given the need for a permanent colostomy in many of these cases. So it wasn't simply just we need a disease-free survival benefit or overall survival benefit with adjuvant therapy. We need to do better with local control. And the first major breakthrough with local control was the development of the total mesorectal excision. Refer back to our surgical episodes with Dr. Bailey, which really just all this means that we're simply removing the fat surrounding the rectum, which contains the majority of the local regional lymph nodes. Makes complete sense with Dan saying that if that mesorectal fascia is involved, it's a high-risk feature. It just makes complete sense. It just means it's invading deeper. So this idea of total mesorectal excision, or TME for short, was really developed in the early-ish 90s and wasn't really widespread use until the 2000s, late 90s time period. So that's one thing that helped. In parallel, both preoperative and postoperative radiation therapy were being studied. There were differing opinions between the North American and European approaches to radiation, and this was based on a few pivotal trials. So long story short, the Europeans preferred preoperative short-course radiation. That was 5 grays delivered in 5 fractions, so just 5 days of radiation at higher doses. After both, a local regional recurrence and overall survival benefit was demonstrated in something called the Swedish Rectal Cancer Trial in 1997. It's important to kind of know that as historical background in this setting. There was criticism in that trial given the lack of required TME technique, and a subsequent study from the Dutch Colorectal Cancer Group that required TME surgeries solidified the efficacy of this short-course radiation before TME, again demonstrating the local regional recurrence and overall survival benefit. In the United States, on the other hand, there was more enthusiasm for long-course, hypofractionated concurrent chemoradiation therapy delivered over 5 weeks, and there was several studies that showed benefit of this in the adjuvant setting. And there was a couple pivotal studies that really showed that in the preoperative setting, we actually improved local regional recurrence and had higher rates of sphincter preservation surgeries after preoperative long-course chemoradiation compared to postoperative chemoradiation. So this is why you'll see long-course preoperative chemoradiation as standard of care in the United States for this reason, whereas in the European studies, they use just short-course, no chemoradiation, just short-course radiation over 5 days with no chemotherapy. And so that's really why you see those two differences.
I think it's so important to understand that historical context in colorectal cancer. Staging imaging and surgical techniques changed significantly, which makes it really difficult to interpret these older trials because we had poor local control and sort of stage migration. In other words, understaging patients because of our technology at the time who in fact had worse disease. This also helps you understand why current trials are incorporating both long-course chemoradiation and short-course radiation. To simplify, there was good data to support both approaches. Let's get back to our patient. He doesn't have a low-lying tumor, but he does have some of those high-risk MRI features with extramural invasion, involvement of the mesorectal fascia, and T4 clinical stage. He's planned for total neoadjuvant therapy with long-course chemoradiation, followed by chemotherapy and then surgery. How do these risk factors affect our decisions overall? And where did this idea of total neoadjuvant therapy come from?
So there were several analyses looking at prognostic factors in local, regional, and distant recurrence in rectal cancer, which is where these high-risk features originally came from. And because there was equipoise with preoperative short-course radiotherapy and preoperative long-course chemoradiation, there were very few randomized trials run to compare the two approaches, but ultimately they found no differences in outcomes. One of the best designed was the Stockholm 3 non-inferiority randomized trial, which randomized patients with resectable rectal cancer to short-course radiotherapy, so that's 5 fractions over 5 days, followed by surgery within 1 week, versus short-course radiation followed by surgery within 4 to 8 weeks to allow for more tumor regression versus long-course chemoradiation over 5 weeks followed by surgery in 4 to 8 weeks. Roughly 20% of patients received adjuvant chemotherapy, and ultimately what they found was there was no difference in local regional recurrence, distant metastasis, or overall survival. It did show that there was more pathologic tumor downstaging when delaying 4 to 8 weeks after short course radiation, which makes sense because you're essentially giving more time for that radiation to work and for those effects to kick in. So this trial, amongst others, is why European countries still often prefer that short course radiotherapy as opposed to long course chemoradiation. And so during this time period, we knew that there was no major differences in outcomes with short course versus long course radiation. So the field shifted towards incorporating chemotherapy and either short course radiation or long course chemoradiation prior to surgery. The thought was to use this approach in higher risk patients to improve pathologic CR, improve surgical outcomes with better tumor regression, and prevent distant metastasis given more patients would be receiving chemotherapy. And the idea of the kitchen sink prior to surgical resection is what we now refer to as total neoadjuvant therapy, or TNT.
The idea conceptually makes a whole lot of sense. You're trying to ensure the patient gets all the therapy necessary for both local and systemic disease eradication. On the flip side, you could be overtreating some patients with too much therapy, which is why patient selection is key, right? You don't want to just say give everybody total neoadjuvant chemotherapy. That doesn't make entire sense there, right? And if you have all of these patients having regression of their tumors and actually taking away the tumors, can we actually omit surgery entirely? And so these are the things that we're going to talk about in the last half of this episode. In our radiation oncology episode, we discussed the Rapido trial and how it pushes you towards long-course chemoradiation as opposed to short-course radiotherapy in our discussion with Nina in that episode. And this was in particular for patients with high-risk MRI features. So can we go through that trial in a little bit more depth?
Sure. So for some background, after the results of the Stockholm 3 trial, which showed that surgery can be delayed 4 to 8 weeks after short course radiation, we saw that there was an opportunity to maybe incorporate some chemotherapy after short course radiation preoperatively during that window. The thought was maybe you could prevent distant metastases without compromising local regional disease control, sniping out that micrometastatic disease systemically with chemotherapy. So the Rapido trial was developed for this, and these acronyms are absurd. It was named for rectal cancer and preoperative induction therapy, followed by dedicated operation. I'll let you figure out which letters they decided to highlight for Rapido. In any event, it is a catchy acronym. The study included patients from both the USA and Europe with locally advanced rectal cancer that was considered high risk by one of the following MRI findings. So T4 or N2 stage, extramural vascular invasion, involvement of the mesorectal fascia, or enlarged lateral pelvic nodes. Sound familiar? These are the features we were talking about earlier. And patients were randomized either to preoperative long-course chemoradiation, followed by surgery, followed by an optional adjuvant chemotherapy for 24 weeks. And that was just at the discretion of the local center. That was their practice. Or they were randomized to the TNT approach, the total neoadjuvant therapy approach, which was short-course radiation, followed by 18 weeks of chemotherapy, followed by surgery. The primary endpoint was disease-related treatment failure, which was a composite endpoint, combining local regional failure, distant metastases, new primary colorectal tumor, or treatment-related death. So in the initial publication, which came out in 2021, they did see a statistically significant improved disease-related treatment failure rate favoring that total neoadjuvant therapy, the TNT approach, by about 7% in an absolute sense, so 23% versus 30%. There were similar rates of local regional control, but the pathologic CR, pathologic complete response, was higher in the TNT group at 28% compared to only 14% in the other group. So double the percentage of pathologic CR. There was a lower rate of distant metastasis favoring the TNT approach by about 7% absolute as well, 20% versus 28%. And we'll have a link to that study in our show notes. At the 5-year follow-up publication, which came out in 2023, there was worse local regional failure rates in the TNT approach compared with the preoperative long-course chemoradiation. So 10% local regional failure in the TNT group versus 6% in the preoperative long-course chemoradiation. But there is still improved distant metastasis rate favoring the TNT approach. And we'll have a link to that follow-up analysis as well. What this told us was that the TNT approach really has high rates of achieving a pathologic complete response, but there's still possibly worse local regional failure with the use of the short course chemoradiation combination as opposed to the long course chemoradiation. I am not the best at analyzing these kind of complex oncologic trials, What are your thoughts on this, Vivek? What do you think about when you hear this data and look through this trial?
I think it's easy to just make the conclusion that long-course chemoradiation therapy is better than short-course chemoradiation therapy because we didn't have this difference in local regional failure rates. But there's a few things that we really need to point out. So one, this wasn't a direct comparison of TNT with short-course versus long-course chemoradiation, right? That's not what this trial was asking. And all of the patients in the TNT group get chemotherapy, while only 40% of patients got adjuvant chemotherapy in the preoperative long-course chemoradiation arm, which could explain this difference in distant metastatic disease, right? It's just that more people are getting chemotherapy in the TNT group, so that makes sense. And I think it is really important to look at the individual components of a composite endpoint. That is critically important because you want to know what's driving that improvement in this disease-related treatment failure. Is it local regional recurrence or is it distant metastatic disease? And in this case, it seems like it's distant metastatic disease. The thing I find really fascinating is that a doubling of path-CR rate in that initial publication with total neoadjuvant therapy did not translate into improved local regional control in the follow-up publication. And this really emphasizes the point we commonly make on this show is that path-CR is not a perfect surrogate endpoint in cancer clinical trials, right? This is a perfect example. These patients had double the rate of path-CR, but ended up having worse local regional failure rates. And then you might be asking yourself, well, then just don't do short-course radiotherapy, do the long-course chemoradiation therapy. But it's really not as simple as that. More of the patients in the TNT arm got a low anterior resection instead of an APR, which makes you wonder if surgeons chose a sphincter preservation given their view of tumor downstaging, but they actually left behind tumor deposits in this group that got the TNT therapy. That's possible. The other thing is the trial wasn't powered for a difference in local regional failure. So this effect size may not be as large as we think. There may actually not be as big of a difference, this 4% difference that we're seeing. And time may have really been a factor. When you look at the TNT arm, there was 40 weeks of treatment prior to surgery. If you look at the long-course chemoradiation group, it was only 25 weeks. So it could be that you just let the tumor sit for too long. That's another possibility in this case, particularly when you're selecting for very high-risk patients, right? And instead of looking at long course versus short course, maybe we need to meet somewhere in the middle to optimize local control and prevent metastatic disease, which Nina had discussed in our radiation oncology episode, right? Maybe it's not just 5 grays over 5 days versus 5 weeks. Maybe there's somewhere in the middle that we need to meet. And I think this trial really just tells us that when we have these path-CR rates, they're not perfect. And is short course radiation the reason why there's less local regional failure rates? It's unclear if it was short course radiation that was to blame for the inferior local regional recurrence rates because of the things I mentioned there.
I think you bring up a good point. 40 weeks is a long time. Remember, there's only 52 of those in a year. So it's almost a year of therapy before getting to surgery. I find this whole concept of total neoadjuvant therapy fascinating, and it will be refined as some of the current trials continue to report out. But let's get back to our patient. He's got a high-risk tumor that is T4 and noted to have some extramural invasion involvement of the meatus of the rectal fascia on MRI. He said that his friend, who's a primary care doctor, looked up intensified chemotherapy with FOLFIRINOX in the neoadjuvant setting. What is the data behind that? Is that something that we're doing now?
This was a French study that randomized patients to FOLFIRINOX followed by long-course chemoradiation followed by surgery versus long-course chemoradiation followed by surgery followed by adjuvant FOLFOX for 3 months or capecitabine monotherapy for 3 months. And so what they found was an improvement in disease-free survival with the TNT approach using FOLFIRINOX, but no difference in overall survival or distant metastatic disease rates. One huge limitation is the fact that some patients got adjuvant capecitabine monotherapy and the standard of arm care. This really doesn't change how we approach TNT, and it also doesn't help us answer short course versus long course chemoradiation using TNT. There's an ongoing trial called the Janus trial that will help answer this question about the role of intensified chemotherapy with FOLFIRINOX as part of TNT, but for now it is not the standard of care recommended for our patients.
Our patient ended up getting long-course chemoradiation followed by FOLFOX, followed by surgery. We let him know that long-course chemoradiation might have improved local recurrence rates as opposed to the short-course option. And after discussing with radiation oncology, he agreed to proceed with that. He's recovered well and remains in remission. I want to switch gears a little bit. to omission of radiation and non-operative management. So trying to see how much therapy we can spare our patients. Last year, in our post-ASCO collaboration series, we discussed the PROSPECT trial, which was presented at the plenary session last year. What did that trial show, and who might benefit from omission of preoperative radiation?
So I'm going to summarize this pretty briefly. This PROSPECT trial, and you can check out our episode where we talk about this in more detail, but essentially it enrolled selected patients. We're looking at earlier stage patients. So they had T2 or T3 tumors that were mid to upper rectum. So these were all sphincter-sparing surgery candidates, no low-lying tumors. And the question in this study was that let's take these patients, again, who did not have any high-risk MRI features, so the opposite of what we did in Rapido, and let's see if we can give them preoperative FOLFOX for 3 months versus preoperative long-course chemoradiation therapy followed by sphincter-preserving surgery. And adjuvant chemotherapy was optional in both arms. And in order to omit the radiation in the chemotherapy-only arm, basically we had to show that the tumor was chemotherapy responsive. So they would get those 3 months of FOLFOX and then get another MRI or another test, and there would have to be at least 20% regression of the tumor. And then they could proceed with surgery. So you can see it's a little bit complicated, but bottom line is there was no difference in disease-free survival or overall survival. And this really told us that in select patients, we can omit preoperative radiotherapy and consider doing like a preoperative chemotherapy approach in some of those patients. We'll talk here in a second about, well, maybe you want to just do the total neoadjuvant therapy, which could actually just be total therapy for rectal cancer and omit the surgery. So we'll talk about it in a second. But in this study, we found that for mid to upper rectal tumors without MRI high-risk features, we can omit radiation safely. And most importantly, there was a patient-reported outcomes publication, where again, we'll link all of these studies in our show notes that we talked about today. And what that showed is that during the neoadjuvant treatment, side effect profile favors the chemoradiation group, which kind of makes a lot of sense. Chemotherapy tends to be harder than chemoradiation. But at 1 year after treatment, there was improved neuropathy, fatigue, and sexual function, favoring the chemotherapy-only group. And there was no difference in bladder symptoms. So these are really important outcomes, and you can see that it's important to consider in younger patients, maybe they would prefer that chemotherapy approach as opposed to the chemoradiation approach based on those 12-month patient-reported outcomes. I thought it was just a great study, and again, we'll link both of those to our show notes. Really read that patient-reported outcomes paper.
I really like that final statement that you made, Vivek, about capturing patient-reported outcomes. We had talked about this as well with some of our guests, and we bring this up quite often in our show because we have to remember that patients are living with these symptoms long-term. So especially in this case, when we're looking at no differences in overall survival in these studies, I mean, that's fantastic. So this concept will be important when we consider omitting surgery. There's now buzz around non-operative management in rectal cancer. So what is the data for this approach?
The best data for patients who are not MSI high comes from the OPRA trial, which stands for Organ Preservation in Rectal Adenocarcinoma. It's really an excellent acronym. This one I will not gripe with. It actually makes sense. I'm surprised they didn't get a cease and desist from OPRA's estate, but that's how it goes. This was a phase 2 study. It randomized patients either to long-course chemoradiation followed by chemotherapy for 16 weeks versus chemotherapy for 16 weeks followed by long-course chemoradiation. So basically induction chemoradiation followed by chemo versus induction chemo followed by consolidated chemoradiation. It included patients with stage 2 and stage 3 rectal adenocarcinoma, and about 70% of patients enrolled had lymph node involvement. The 5-year follow-up, which was published in JCO this year in 2024, about 50% of patients did not need surgery at 5-year follow-up for patients who got chemoradiation first, followed by chemotherapy. This was better than the chemotherapy first group, where about 40% of patients did not need surgery at their 5-year follow-up. Like we discussed in our surgery episodes, these patients require a lot of monitoring. So really intensive monitoring with FlexSig and MRI. So they have to be willing to stick to that surveillance for this to really be a safe plan. At first, the schedule is every 4 months for 2 years, and then every 6 months for 3 years. We'll link to that OPRA trial in our show notes as well.
I think it's really important to think about this breakthrough in rectal cancer. This is huge. we're omitting surgery for one of these tumors. That's truly, truly incredible. And this surveillance schedule isn't that bad even, right? It's not like every month the patient's having to come back. So it'll be really important to see patient-reported outcomes, how this plays out in the future, and really cool to see this space evolve. So let's finish off with the groundbreaking immunotherapy trial for MSI-high patients. Remember, that piece of information is critically important when we first meet these patients. So, Rona, can you go over the immunotherapy trial for our patients with rectal cancer who have MSI-high tumors?
Looking back, I remember when this study came out because it was all over the lay press. Everybody was talking about it. And I actually think I was in GI clinic at the time and patients would come in asking about this. So to remind you all, there was a single center phase 2 study published in the New England Journal of Medicine in 2022, looking at stage 2 and stage 3 patients with rectal cancer and MSI high tumors. So there were 12 patients enrolled and given the PD-1 antibody called dostarlimab, and this was given every 3 weeks for 6 months. And there was a 100% complete response rate and no patients proceeded to chemoradiation or surgery. So you can imagine this is why this was all over the news. 100% of patients enrolled in this study, granted there were 12 patients, given this medication, did not have to proceed to chemoradiation or surgery. And so this was truly an incredible breakthrough for patients and the use of immunotherapy for non-operative management in MSI-high patients. This was established as the standard of care. I mean, again, now we've highlighted 2 different studies that have shown us that maybe surgery isn't required for everybody. And so I think that this nicely fits into this era of precision medicine and trying to create the optimal treatment paradigm for each individual patient as opposed to sort of a one-size-fits-all. Really, really exciting stuff.
I definitely agree. And just as we finish out the episode today, all of our listeners need to remember this is why you need to know the MSI high status. It is so important. Remember to get that pelvic MRI to look for high-risk findings. And then just remember, there's equipoise for long-course chemoradiation over 5 weeks and short-course radiation 5 fractions for 5 days. Yeah, we have the Rapido trial and some of these other things, but there are nuances, and watch out for the new data coming out. We have not done a trial comparing head-to-head TNT using long-course chemoradiation or versus TNT using short-course radiation. So it'll be really interesting to see how this field evolves, if intensified chemotherapy comes into play, and how do we get the patients the highest chance for an organ preservation route without surgery.
Vivek, I thought those were fantastic recaps. I have nothing to add to that. So I think this is a great place for us to wrap up today's episode. Thank you all for a great discussion. So until next time, we'll see you all later.
See you later.
Peace.